Hello and welcome. My name is Benita Katz. Recently, there's been increasing interest in defining physiologic birth. As you'll see in this video, the definitions vary from one organization to another. A couple of notes before we begin. Although the definitions will be printed out on each slide, I will not read each word. I'm assuming you can do that. I will, though, discuss the meaning and implication of the definitions. To see the sources for this material, please look at the references at the end of this presentation. One other note, I use the term physiologic. Many of the sources we will look at use the term physiological. They both mean the same thing. I have simply chosen to use the shorter word. Now, these are terms that we often see in the literature. Natural and normal, those are pretty vague terms. Some would say that a normal or natural birth is any birth that is not a cesarean. Others would say that a natural birth is one that is unmedicated. It's significant that many of the ways we try to define physiologic birth describe what it is not: unmedicated, uncomplicated, undisturbed. This tells me that on some level, we realize that what we often see during labor and birth is not as it should be, and yet we have difficulty describing exactly what we expect. Perhaps this is due to the wide variation that we see: long labors and short, difficult labors and not so difficult ones, positions and comfort measures that work for one woman but not for another. Some would say we cannot define physiologic birth because many healthcare workers have not actually seen one. Medical intervention in labor and birth has become so commonplace that we've no idea what a truly physiologic birth looks like. This series of videos will look at the various aspects of physiologic birth. But before we dive in, I'd like for us to consider the implication of the specific words we use. To some extent, this will reflect my preferences and experience, but I hope that it sparks some thought on your part about how we think and speak about birth. Also, consider looking at the summary report called Rebirth, or RE:birth, that's been published by the Royal College of Midwives. They've done an extensive study on the words we use about birth and the effect that those words have. Using the term delivery instead of birth seems more medically oriented, more procedural, and less transformational. Throughout this series, you'll hear me say that birth is more than the physical process of moving the baby from the inside to the outside of the mother. Especially when we consider the hormonal component of labor and birth, we will see how profoundly mental and emotional processes affect the progress of labor, and how the progress of labor affects women mentally and emotionally. Pregnancy, labor, and birth are transformational experiences in the lives of all who are close to it. Mothers, fathers, and infants, of course, but also extended family and even healthcare providers. Our words should reflect this. Birth is transformational for everyone touched by it. Another word to consider is risk. With that one word, we have introduced fear into the birth environment. Saying there is a chance of something, a baby large for gestational age, for instance, is acknowledging a fact. It introduces information that can help a woman in her decision making. Is there any way we can share information without introducing fear? Most of the time, I believe the answer is yes. Now, let's begin with the definitions. In the 1990s, this is how the World Health Organization defined physiologic birth. They used the word normal instead of physiologic, but let's break this into smaller sections as we take a look at this definition. A normal delivery, they say, starts spontaneously and has only low risks identified at the start of labor. This idea of labor beginning on its own is common to many, if not all, definitions of physiologic birth. The implication is that induction of labor is not normal. It interrupts the usual physiology of labor, and that makes sense. But here, in the very first sentence, the concept of risk is introduced. I'd like to see us do a health assessment that ended with a summation of likelihood of healthy labor and birth, as opposed to low risk. I'll ask you again to think about how our thinking is shaped by the words we use. Again, risk is mentioned as continually assessed risks. What does this do to the provider's mindset if they are constantly looking for what might go wrong? Now, I understand the meaning behind this. The provider's job is to consistently and constantly assess, but what if we looked for assurance of normal process instead of assessing risk? Would that change the prevalent attitude of the birth environment? In this definition of the World Health Organization, again, it says a baby must be in a vertex or head first position for the birth to be considered normal. This negates the possibility of breech birth ever being considered a variation of normal, even though the vast majority of breech babies can be birthed without harm. One of the issues in defining physiologic birth is establishing an acceptable threshold of risk. Sorry to use that word. That is not something we can address here, but it is something we have to consider when defining physiologic birth. Going on in this definition, normal birth would have to occur between 37 and 42 weeks of gestation. Normal vital signs during and after birth are also considered a part of a normal birth. A serene and parent-child attachment are the only nods to the psychosocial aspects of birth in this definition. Now, in 2017, the World Health Organization issued another document that continued to support the earlier definition, but with these additions. The possibility of amniotomy, which is the artificial rupture of membranes, postpartum Pitocin, and IVs. When necessary, augmentation of labor and pharmacologic pain relief may be administered. So, although the definition calls for the respect of the normal rhythm and physiology of labor and birth, it also allows for medical intervention when it is warranted. This really muddies the waters when trying to define physiologic birth. Does the fact that an intervention is commonly done make it part of physiologic birth? And now we begin to see the need for a universally accepted definition. The International Confederation of Midwives has put forth this definition. Some points echo the WHO definition: vertex presentation, born spontaneously at term. The very first statement here recognizes that each labor and birth is a unique and dynamic process. This allows for the consideration of many factors that can influence labor progress and birth outcomes. They also recognize the significant contribution that a woman's psychosocial environment makes. They contradict the 2017 WHO definition by saying that a physiologic birth is without surgical, medical, or pharmaceutical intervention. This definition is the one agreed upon by the following American midwifery organizations: the American College of Nurse Midwives, the Midwives Alliance of North America, and the National Association of Certified Professional Midwives. As with the previous definitions, they include spontaneous onset of labor and vaginal birth, although unique to this definition is the inclusion of the birth of the placenta. Conditions that promote effective labor include both physical and psychological elements. They note physiologic blood loss, but the amount is not defined. Skin to skin in the immediate postpartum is expected, as is the initiation of breastfeeding. The Society of Obstetricians and Gynecologists of Canada categorizes birth in 3 ways. Natural birth and normal birth both share several characteristics: spontaneous onset at term, head first vaginal delivery. The difference between the two is the use of medical assistance. Natural, meaning that no assistance was given, and normal, meaning that some interventions were used. Operative vaginal birth using forceps or vacuum, breech, cesarean, or VBACs are considered assisted births. Now, I found the reference to this definition in the Labor Progress Handbook by Penny Simkin, Lisa Hansen, and Ruth Anchetta. These authors state that this definition most closely embodies the approach to labor and birth found in that book. This concept of the woman's control and sense of achievement is missing from the other definitions. Although some of the others recognize the significance of the psychosocial environment, they do not mention the mother's active participation. So I'd like to kind of wrap things up with a summation of this article by Brooke Henshaw and her colleagues entitled, What is Physiological Birth? A Scoping Review of the Perspectives of Women and Care Providers, published in 2024 in the journal Midwifery. The authors reviewed 24 articles published between 2013 and 2023 with this goal in mind: to provide conceptual refinement to assist health professionals in identifying the boundaries of physiological birth within clinical practice, and to explore how the perspectives of women can be reflected by its defining attributes. These 3 questions were addressed in the article. To answer the first question, even in such a thorough review of the literature, they found no consistent definition of physiologic birth. The authors also made note of the fact that in none of the studies were women asked their perception of physiologic birth, nor were they included in trying to develop a definition. Definitions focused on medical and biological processes, and none of the studies considered explained the source of their definition of physiologic birth. The concern here is that without definitive terminology for physiologic birth, miscommunication and misunderstanding could easily lead to lower satisfaction for childbearing women. This satisfaction is not just about making women happy. Because birth is a transformative event, that sense of satisfaction can have profound and long-lasting ramifications in the lives of women and their families. In response to the second question, how is physiologic birth perceived among care providers, it's interesting to note that in none of the studies were obstetricians asked to define physiologic birth. The midwives surveyed described care in the hospital as risk-oriented care, which increased medical intervention. They were concerned that this limited a provider's opportunity to witness labor and birth in a way that was truly undisturbed. In fact, the midwives were hard-pressed to define physiologic birth without saying what it was not, just as I mentioned at the beginning of this presentation. Also, in this risk-oriented environment, the midwives stated that providing care is both physically and emotionally demanding. Providers try to balance institutional requirements and the wishes of the women they serve. This can be pretty stressful. The other part of the second question asked about a woman's perception of physiologic birth. Because the care of childbearing women is centered in a risk management approach, many women question their capacity to birth without technological aid. A woman-centered approach supports a woman both physically and psychologically. She needs to understand the labor process and birth options. When she is supported and involved in the decision-making of her own care, her satisfaction with the birth experience is improved, resulting in a sense of empowerment, safety, and joy. The third question addressed the challenges or barriers to providing a physiologic birth to women in a hospital setting. As medical interventions become more commonplace, and I'm thinking of things like the use of epidural anesthesia and induction of labor, it becomes more difficult for a healthcare provider to observe a truly physiologic birth. This, in turn, influences a provider's philosophy of birth. The medicalized environment affects not only the childbearing woman, but the providers as well. Providers need support, not only education on physiologic birth, but also emotionally as they navigate the demands of a litigious society, institutional requirements, and the woman's birth preferences. Women need support, such as childbirth education that gives them the information necessary to make wise decisions for themselves, and emotional support throughout labor, birth, and postpartum, as can be given by a doula. This quote is one of the key conclusions in this article. And here it is. If the dominant culture in a birth suite exhibits a hierarchy of medicine, midwifery, and then the woman, care provision tends to become aligned with a medicalized model. This challenges us to reorder how we think about birth. Consider this. Pregnancy and birth are the only healthy conditions for which we seek medical care. The predominance of education for medical providers focuses on illness and injury. We need those providers when things are not going well. But the fact is, the majority of the time, the majority of women will have a healthy course of pregnancy and birth. It is time to reorder our thinking, to take time to observe the undisturbed, unmedicated process of birth so that we can better understand the actual physiology of it. As we will see in some of the following videos in this series, physiology is not only about the physical process of birth, but also about the emotional and psychosocial aspects. Women are not simply physical beings. We are whole people, having body, mind, and spirit. We function in a society of other people. Birth is not just the baby's physical change of location from the inside to the outside of the mother. When a baby enters this world, a mother and a father are also born. This is one of life's most transformational events. It is good that we are careful, watching over the process of birth. The dilemma we now face is finding the line between watchful care and interference. Hopefully, as we explore the concept of physiologic birth, we can better define just what it is and how to support it. Thank you for listening. I'm Bonita Katz with Mountain Perinatal Education. Stay tuned for more videos about physiologic birth.